86% мужчин лечение продолжают. И, в общем, на наш взгляд, эта цифра очень высокая, она, скажем так, оказалась лучше, чем мы ожидали, наверное, полностью это лечение оплачивает, если пациент активно участвует в принятии изначального решения. Поэтому, говоря о роли дополнительного 5 мг для приема возрастных для лечения эректильной дисфункции в настоящее время, еще раз отмечу, что это единственный ингибитор после регистрации этого типа, который применяется на ежедневной основе. Это препарат, который позволяет мужчинам не планировать сексуальную активность при ежедневном применении препарата. Это препарат, который дает дополнительный положительный результат при недостаточной эффективности приема разных ингибиторов после регистрации этого типа по приему. Это препарат, который показал, по крайней мере, насколько мы это знаем, хорошую приверженность пациентов к терапии, если они начинают. Опять же, последние несколько лет мы активно говорим о том, что ингибиторы после регистрации этого типа разные, они уменьшают выраженность симптомов нижних путевых пути у пациентов с высококачественной гипоплазией предстательной железы. Мы помним, что из всех этих препаратов для лечения симптомов АДТПЖ зарегистрирован только скарлатин 5 мг и исследователи недавно задались вопросом о том, будет ли улучшаться у таких мужчин мочеиспускания, если назначить скарлатин 5 мг тем пациентам, у которых нет эректильной дисфункции. То есть назначить препарат только для того, чтобы мужчины начали лучше мочиться. И было также большое исследование, одно, второе, третье, затем мы проведем объединенный анализ, и оказалось, что да, препарат имел положительное действие таких пациентов, у пациентов уменьшался как общий балл ПСС, так и при отдельном анализе по шкалам, также имелось положительное действие препарата, в частности, на симптомы опорожнения. Поэтому в данном протоколе мужчины с эректильной дисфункцией, сходные без эректильной дисфункции, они имели схожие исходные характеристики, кроме того, что среди мужчин с эректильной дисфункцией закономерно было больше пациентов с диабетом и патологией сердечно-сосудистой системы, и препарат релатив 5 мг для таких пациентов работает. То есть выраженность симптомов нарушенного мочеиспускания, и качество жизни, они у этих пациентов изменялись в лучшую сторону. Несколько лет мы активно говорили о том, что да, ингибиторы после регистрации этого типа работают у пациентов с АДТПЖ, уменьшают симптомы, однако максимальная скорость мочеиспускания не улучшается. Это было предметом большой дискуссии. Эта дискуссия, я бы сказал, раскрылась в 2012 году. Приема продолжительного 5 мг на день, максимальная скорость мочеиспускания улучшается. И эта дискуссия не затихла, продолжалась, и совсем недавно был представлен анализ 4 исследований, рандомизированных, двойных, плацебо-контролированных, по результатам которых при суммировании данных было проанализировано, как изменяется показатель максимальной скорости мочеиспускания, если пациенты принимают продолжительно 5 мг один раз в день. Оказалось, что имелось статистически достоверное увеличение показателя максимальной скорости мочеиспускания. Опять же, мы должны понимать, что мы говорим про достоверность, то есть она не такая большая, но она достигла статистической разницы. Поэтому мы знаем, что да, изменяется суммарный ПСС, да, изменяется и уменьшается по шкале опорожнения, и мы знаем теперь о том, что есть небольшое увеличение максимальной скорости мочеиспускания. Когда мы начинаем это обсуждать, мы, конечно, помним с вами, что, к сожалению, показатель максимальной скорости мочеиспускания, он не так хорошо реагирует симптомы, как нам бы хотелось, с обменом достаточно мочи. И группа экспертов, американских урологов, даже сделала такое, как бы выпустила стейтмент, утверждение о том, что показатель максимальной скорости мочеиспускания оценивается мужчинами плохо, потому что мужчины-пациенты, они не способны хорошо определять достоверные различия скорости мочеиспускания. Другой вопрос, который опять же продолжает активно обсуждаться, это возможность сочетать применение релатива 5 мг на день с какими-то другими группами препаратов. Что происходит с симптомами нарушенного мочеиспускания, с эректильной функцией. если пациенты принимают или плацебо с фенофилином, или продолжил 5 мг на день с фенофилином. В данном протоколе средний объем простаты у мужчин при учетных исследованиях составлял примерно 50 тысяч см, среднее значение ПСА исходно примерно 2,5 мг. И оказалось, что мужчины, которые изначально принимали фенолфил вместе с фенофилином, они имели достоверно более выраженное улучшение симптоматики, чем те мужчины, которые принимали фенофилин вместе с плацебо. При анализе состояния эффективной функции пациента показалось, что за то время исследования, которое продолжалось не так долго, в группе фенофилина достоверно сексуальная функция не менялась, а те мужчины, которые принимали фенолфил вместе с фенофилином, они не только не имеют какого-то ухудшения эффективной функции, что, в общем, мы нередко наблюдаем пациентов, принимающих ингибиторы 5-реактазы, но, напротив, они отмечали достоверное увеличение среднего плана. Был закон о хорошей эффективности комбинированного лечения, включающего в себя ингибитор 5-реактазы и предложил 5 мг для приема один. Ну и, наконец, несколько слов в отношении того, как работает фенолфил у пациентов, у которых нет предстательной железы, у которых предстательная железа удалена в ходе дикальной простатотомии. В этом году, буквально 1,5 месяца назад, на Конгрессе Европейской ассоциации урологов, мы представляли данные российского исследования, которое было проведено в клинике урологии МСВ. В данном исследовании оценивалась роль фенолфила в восстановлении движения мочи после нервосберегающей тестированной дикальной простатотомии. Пациентов было включено не так много, но тем не менее была группа больных после травматической радикальной простатотомии, которые получают 25 мг на день, были пациенты, которые получают 20 мг по требованию, и были пациенты, которые получают плацебо, и среднее время наблюдения за пациентами оно составило 24 месяца, то есть чуть-чуть больше было, чем 2 года. И оценка мочевой пустоты, она проводилась при помощи международного моделизированного опросника, это был опросник UPA-50, в котором 100 баллов соответствует максимально хорошей функции, и оказалось, что те пациенты, которые принимали 25 мг на день, они имели более быстрое восстановление движения мочи по сравнению с теми пациентами, которые получают плацебо или которые получают 20 мг на день. Ну, это интересные данные. Мы прекрасно помним, что назначение фенолфила 5 мг на день, оно не показано для улучшения движения мочи, однако это был тот феномен, с которым мы столкнулись, анализируя состояние данного пациента. Поэтому, заключая все, что было сказано, я еще раз хотел отметить, что терапия фенолфила 5 мг на день, она позволяет выработать симптомов нарушенного общедискальных пациентов ГПЖ вне зависимости от расходного вала КСС, объема предстательной железы, возраста пациента и приема прошлого антидота. То есть препарат для уменьшения симптоматики ГПЖ работает у самых разных категорий пациентов. Приверженность пациентов терапии высокая, и если пациенты принимают фенолфил 5 мг на день, то это лечение оказывается эффективным для уменьшения выработки симптомов нарушенного общедискального у мужчин. И зрительный достоверно улучшается максимальная скорость воздуха мочи, однако я еще раз подчеркну, что клиническая значимость этого феномена, она остается спорной, и ценность ее, наверное, должна быть вполне изучена. Сочетание применения сервиса 5 мг и ингибитора 5-реактазы является более эффективным, чем монотherапия с ингибитором 5-реактазы, но, наконец, существует дополнительное преимущество приема 5 мг на день у самых разных категорий пациентов по разным показателям, и урологи по всему миру продолжают это изучать в настоящее время. Я благодарю вас за внимание. Спасибо.
С большим вниманием мы их выслушали. Я думаю, что особый интерес представляет, вот с моей точки зрения, как онкоуролога, второе сообщение, не просто касаемо коррекции восстановления эректильной функции у пациентов вообще, а именно после радикальной простатэктомии. Проблема очень серьезная, которая обсуждается очень активно сейчас. И вот мы видим, что есть реальные средства, которые могут способствовать.
Mr. Chairman, ladies and gentlemen, the treatment of distal hypospadia is well, a bit bothersome, you can say. When you look to the literature, there are many different procedures described, but gives always the impression that no one is really ideal. But I will tell you about the tip going back to Snodgrass and our experience in this field. About the incidence and etiology, the incidence of hypospadia is rising in the last 40 years. There is a very good Finnish study which showed that the incidence rises at about 10, from 1 to 10. Now we have 4 to 8 babies per 1,000 deliveries, and in the past it was 1/10 of this incidence. There is a deficiency. And you may have a curvature by the severe forms, and the meatus may be very thin and narrow. Sometimes you don't have a testicular descensus in the scrotum, also showing that there was a deficient viralization during pregnancy. So this kind is very suitable for the TIP procedure. It was first described by Thiersch in the 19th century, and the first modification by Duplay in 1880. And a new modification was published in 1994. You have a dorsal incision of the urethral plate with tubularization of the of the urethral plate to make an advancement of the urethra. And you have to cover the neo-urethra with an intermediate layer in order to well, to have less fistula. And best you take the mid portion of the foreskin, and then you have to reconstruct the shaft and the glans. So you can see this in this picture, that here you make the dorsal incision in the urethral plate, and then at the glans, then you have to advance the skin of the glans, and then you can, with a running suture, you can close it so that well, you have the urethra advanced to the tip of the glans, and afterwards then you have to take the mid portion of the foreskin and to lay it over this neo-urethra. Well, we always do a circumcision, and afterwards the cosmesis is very good. We had a short study with 34 cases, 7 penile, 4 glandular, 12 subcoronal, and 11 distal penile cases. From 2010 to 2013, ages were between 13 months and 9 years. Mean age was 3.5 years, and follow-up between 4 and 24 months. There were 7 surgeons and 1 staff supervising the procedure. Mean operating time at about 100 minutes. We took a urethral stent of 8 to 10 Charrière, and the first dressing change at the 5th post-operative day, and afterwards, in most of the cases, the patients could go home. So the mean hospital stay was, I don't know why it is not, okay. There were concomitant malformations, Vater association in 1 child, esophageal atresia in another child, gastroesophageal reflux in 1, and posterior urethral valves in 2. And they were diagnosed post-operatively following urinary tract infection. Well, in the course, the post-operative course, there was a defective micturition in 8 without stenosis, and in further 3 with stenosis, and 2 fistulas. By deranged micturition, we performed a uroflow to look at the obstruction, and then we performed a buginage in 11 cases. That was in 32% of the cases. There was no stenosis in 8, and after the 1 buginage, there were no problems anymore. And in 3, we had to do relapsing buginage for 2 or 3 times. Successful buginage was possible in 2 of the 3 cases, and in 1, we had to perform a cold meatoplasty. The fistula could be successfully repaired with the darter's flap in the 2 cases. So in conclusion, a post-operative deranged micturition can occur in 1/3 of the cases, but in 6% long-term post-operative results were good and the cosmetic results were excellent. The parents and the children were were satisfied with the procedure, and in 2 patients we had the peculiarity of posterior urethral valves. Here you can see the post-operative cosmetic result, and you see that the meatus is like a slit, so it is like it has to be, and in contrast to, for example, the Mathieu procedure, where the meatus is always in an oblique form.
Прекрасный доклад. Вопросы будут из зала нашему лектору? Пожалуйста, подойдите к микрофону.
Скажите, пожалуйста, на ваш взгляд, рассеченная площадка постнотгресс замещается чем? Уротальным эпителием или же рубцовой тканью?
Also Verband oder was?
Neue Teil, neue Röcke. Später kommt ein Epithelium dort.
Also das ist in,
oder kommt eine Narbe.
Nee, that's, no, it is no scar tissue that is rising. Oder wollen Sie es auf Russisch übersetzen? Also es entsteht keine Narbe, weil man halt die Fossa navicularis und eigentlich das eigentliche Gewebe, das man in dieser Uretralplatte hat, weil man das tubularisiert, hat man kein Narbengewebe. Hier,
Так как во время этой операции используется пластинка, которая состоит из своих тканей, и после пластики, когда эта пластинка превращается в трубку, там сохраняются естественные эпителии, естественные клетки, поэтому там рубцевания как такового нет. Она затягивается, да.
Вопросы есть еще? Вопросов нет, мы поблагодарим за прекрасный доклад. Спасибо большое.
Okay.
Слово предоставляется Вольфу Виланду, диагностика и лечение стрессового недержания мочи.
Dear Chairman, ladies and gentlemen, dear colleagues, okay, I will talk about diagnostics and therapy of stress urinary incontinence. The incontinence for a woman is impeding, is incriminating, affecting her life, and is misunderstood in many of the cases, and is still a taboo. So that's the reason why a lot of women don't go to the doctor and don't want to, they are ashamed to talk about this problem. So if you go to the definition of urinary incontinence, so it means that every involuntary leakage of urine which is considered as a problem from the patient's point of view. So it means that every when you are losing urine, so you this is with coughing, laughing, and so on. That is the point that you have an incontinence. If when we talk about incontinence, we should go first for the anatomy, and it is very important when you look at the female anatomy and you see there is 3 parts you should look for, and therefore it's not only a neurological problem. In a lot of the cases, it's a problem also for the gynecologist and also for the proctologist, for the surgeon who does proctology. We work very well together with Alles Fürst in Regensburg. We have an own pelvic floor center, and this works very well, and the patients are very happy about this. So female lower urinary tract, you have these special sphincters. I don't want to go further on this. Everybody of you knows this. So the innervation of the bladder is very, very complicated. I don't want to go deeper in this, but you see, this is there are sympathetic nerves, there are vagus nerves, this is the nervous pelvicus. They have a lot of ganglions which interferes this, and they have a somatomotoric, and also the nervus pudendus is also works on this innervation of the bladder, and the system of relaxing the bladder and you can normally avoid is a very complex situation. Okay, the main causes for urinary incontinence are stress and urge incontinence. In female, mostly stress incontinence. So classification of urinary incontinence is the stress, is the involuntary leakage of the urine at a physical strain, what we have also talked about it. Urge is the involuntary leakage of urine with either concomitant or preceded urgency to void. It's what we call, I think also the same in Russia, imperative mixtion, you know. And then they have a mixed that is quite often between urge and between stress. So other types of urinary incontinence, you know, overflow incontinence is with a residual urine. It's, for instance, with a prostate obstruction. Some of these patients have a so-called overflow incontinence. And you also have extraureteral incontinence, which is from ectopic ureters or fistulas or ureteral diverticula. It can be also a mechanism which causes incontinence is the hypermobility of the urethra, a change of the position of the urethra and the bladder neck in case of sudden increase of abdominal pressure. And no compressive occlusion of the urethra during physical effort that can that reacts in a higher pressure in the bladder than in the urethra, and so you have a situation of incontinence. So you can also have a hypotonic urethra. It's the pressure closure of the urethra is less than the pressure inside the bladder. So you can also have a reduced transmission to the pelvic floor in women, especially after some pregnancies, and therefore you have a descensus, and the transmission is not on the right way. It doesn't go like this; it goes like there because the bladder is going down, and then you also this can be also a result in incontinence. So you also can have some other pathological results when you have a posterior urethra, when you change this angle here of this posterior uretrovesical angle. When you have a cystocele, you have a vertical cystocele or a rotatory cystocele, so it can be also cause incontinence. And now we come to a very important part. This is the integral therapy, which is done by Ulmsten, 1990, and this explains how stress incontinence and also urge incontinence can happen, because there are some excuse me. There are some receptors in the vagina, and if you have a descensus of that, then so you can happen that these receptors are active, and so you can happen in an urge incontinence. And when you do these operations, like we see later, so you can not only make a therapy of the stress incontinence, you also can do a therapy of the urge incontinence. So, usually the vagina is like a hammock for the urethra, and this is also very important because you see here, if this Querschnitt, that means this diameter of the rhabdo sphincter is smaller, you have a better pressure function. When the rhabdo sphincter is a little bit wider, for also what happens when you have a descensus, then the sphincter compression is less. So what we already talking about is you have mostly, you have quite often a mixed situation between stress and urge. You see, stress is the most important one, but you have also a mixed situation in 29%. It means that both are relevant. So what are the risk factors for female incontinence? One thing is age, vaginal deliveries, and obesity. These are the main risk factors for female incontinence. And so what go a little bit more accurate to these risk factors, you see here the gender, the race, the physics, anatomy, like obesity, what I told you. Then you have childbirth, hysterectomy, vaginal surgery, or radiation therapy. Then you have obesity, menopause, constipations, with a lot of pressure. The patient always tries to have to avoid this constipation. Then you have a decompensation in the age, or in the patients, or with old patients who are dement, and you have also you can interfere these risk factors with changing your lifestyle. That means you have to lose weight. If you are for obese patients, you can use some medications and you can do some surgery. What we're talking about a little bit later. Epidemiology, the prevalence is strongly depending on the definition you use. There are different definitions. I don't want to go deeper to that, but it is very similar. So the gender differences in incontinence, you see the male incontinence has a progress in the age. So it depends on some subvesical disorders like prostate hyperplasia and so on. And in the age where after women have birth or something like this, so they have the high progression of incontinence. So age-related prevalence of female urinary incontinence, you see, it's only talking about the female incontinence, which is it's a very high level between the 40s and the 50s. Childbirth, what I also already told you, is a very, very big factor, especially if the guidance of the birth is not very well done by the gynecologist. So urinary incontinence, you see, is more common than other chronic diseases in women. You see, it's more common than hypertension, depression, or diabetes. So it's a really big and a very common problem in urology. Everybody of you knows this. It goes, you know. So I have some clinical pitfalls, but I think I will will go for, over these pitfalls. It will be last too long. It's like a test we have done, but I want to do. I don't want to do this here. Okay. So the diagnostics, you know, medical history is very important. You have to ask the patient some important question, and you have to ask him: do the discomforts occur suddenly? When did the discomfort occur for the first time? Use of incontinence. How many pads you are using? How many per 24 hours? How are the intervals of the micturition? Do you have nucturia? And how is your fluid intake? And it's very, I think it's very, very clever to give the patients a paper where they have to write how much they drink and how often they have to go to the toilet, because most of them are not able to think about this. So when they see it on this paper, they have done it for itself, so they are conscious about this. So you have to do an abdominal examination for ascites, tumors, anal tonus, coprostase, residual urine. Then you have to do a bimanual palpation, a digital exploration of the rectum, assessment of measurement of the contractility of the anal sphincter, and you can do an ultrasound examination, what I show you now. You know, so if you have a patient with incontinence, you really have to do a good examination and a good anamnestic and very good and very accurate anamnestic questions to the patient. So the purpose of the examination for the pelvic organ prolapse is to look for diverticula of the urethra, estrogen status, inflammation, function of the pelvic floor, and so on and so on. So you also have to do sometimes a neurological examination of the sensibility and the motoric innervation, especially around S2, S4, the somatic and parasympathetic nervous system, supplying the bladder, urethra, rectum, and the anal canal. And you also have to look for the perineal sensitivity, motions and innervations of the lower extremities, and you also can check the bulbocavernosus reflex. So what is basic? You have to do a urine analysis, and then you have to measure the residual urine volume. Then additional elementary tests are tests for urine loss, a stress test or a cuff test. You can see that. You should do that with the patient in the upright position and also when he's lying. And quantitative measurements of short-term PET tests performed in the hospital mostly, and long-term PET tests performed at home. So you should do a subvesical examination also. You should look, is there a stricture in the urethra which mostly causes an urge incontinence. So you should do a cystoscopy with a rigid or with a flexible cystoscope. Then what we learn from the gynecologist is an ultrasound of the introitus vagina. And when you ask the patients to press, here you see wandering of this urethra, how it changes. And so you can see some descensus very easily only with this ultrasound examination. So also have to do an anorectal ultrasound if the patients also report about some stool incontinence. Then you have to do, in the severe cases, the urodynamics with cystometry and everything what every urologist has in his repertoire. Then you have to do a vaginal examination, and the cystoscopy we already have done. Then this was a video where you can see emptying the bladder, but it doesn't run. It only shows that it's the way how the micturition is going on. Then you can make this test with a stick to see how the urethra moves, and you can see also the pressure which goes from the urethra. And every fact that disarranging the balance of the direction of the urethral pressure may have a positive effect, that means that can cause incontinence. So it is, you can make a therapy, that means weight loss, surgery, or pelvic floor exercise with medications. These are the specific and the most important goals for the planned therapy. Then you see also you can give the patient in the meantime these special pads, and what is also important, first of all, especially with young patients, we don't do the operation, the surgical therapy as a first step. We try to tell them, please do a very professional and a guided pelvic floor exercise. And then in a lot of the cases, you win a lot of years till you have to operate these patients. Then you can do that also with electric stimulations. Some patients like this, some don't want it. So you can do that also in a biofeedback support, which gives the patients information how he does it in the right direction. Then, if you have a long descensus or a very strong descensus, especially in older patients, you can use some Pessar's cubes. Now let's go to this part which interests us as urologists, especially, is the surgical therapy of stress incontinence. The surgical therapy displays the last step of the treatment of the stress in urinary incontinence. It should only be performed after detailed consulting and education of the patient. Detailed diagnostic I already talking about. So some have tried submucosal bladder neck injections with collagen or some what else. We don't do that. We have never done this because mostly in the end it reacts in a stricture or in a rigid urethra and makes not then when you do a surgery after this, the surgery can fail when they have these submucosal injections. So what everybody knows is the tension-free vaginal tape was first since 1990, which was created by Mr. Olmston after he explained his theories, and you can do this TVT, or you can do the transruptural tape, this so-called TOT. I just want to mention that we are doing the TOT mostly in older patients. If the patients are still active with sex, so you should not do that with younger patients because they can have with a TOT some pain during the intercourse. So when it's with a younger patient, you should perform a TVT or perhaps a Birch Kolber suspension if you have to talk with the patient. This has the same result like the TVT, but it's an operation. But you can also do this laparoscopically now. So the results of the sling procedures are equal to the Birch procedure with a cure rate for a long time of 75%. The advances of the sling are less invasive, less de novo urge, and less bladder outlet dysfunctions. What about men? Several sling systems now are on the market, have been established in the male urinary incontinence. Most frequent cause of male incontinence is radical prostatectomy or after TURP. So what is the hypothesis? It's a compression of the bulbar part of the urethra, generating a mild subvesical obstruction and regain a continence. You can only do that in patients who have a stress 1 or 2. If you have a patient with a complete incontinence, that is not an indication for this type of operation. So what we are using this Argus kit. I show you how it looks like. It's like you can use it like a TOT. The advantage of this Argus kit is that you can, if this is you can see after the operation that it is is not firm enough, it's not strong enough. You can only go to this part of this sling, and you can make it stronger. So it's only a little cut, and you can change the strengthness of this sling. So you can also do this retropubic. So that is a technique we haven't done it, but it's also used for male incontinence. Is a so-called advanced sling, which is the same physiological way as this Argo sling, only compression of the bulbar part of the urethra in another technique. So if you have a patient with a stress incontinence grade 3, so the only way is a so-called artificial sphincter, which it works very, very well. It's a so-called Scott sphincter, and I think as urologists you know how this works. You know, you have a cuff around the bulbar urethra, and you always have this cuff with a reservoir of water, and when the patient wants to urinate, then he can empty this cuff into the reservoir, and after he's emptied the bladder, he can pump here the water again in this cuff, and he's continent. So medical therapy options, you know, it's approved with duloxetine, especially in patients who have some incontinence after radical prostatectomy. An additional medication is especially in urge incontinence, anticholinergic agents or spasmodic agents. And in women, you can try first, on the first step also, besides physiotherapy, estrogens in the vagina. So theoretical effects of the estrogen in the urethral sphincter, everybody knows of you know, that makes an increase of the subepithelial vascularity, and they have a better trophic of the whole mucosa of the urethra and the vagina. So summary, stressing urinary incontinence is a disease with massive relevance and underestimated prevalence. The doctor must get the patient out of the dirty corner and offer her help. There are many and effective methods of the therapy today, and it should be not any longer a taboo. And this is very important that you talk with the patients. And what is also very important, it's an interdisciplinary fashion between the urologists, the gynecologists, and the surgeons. And thank you very much for the audience, and show you a picture of the old city of Regensburg, which is very famous. This bridge is built on the around 1200.
Спасибо большое за прекрасный доклад. Вопросы будут? Вопросов нет, всем все понятно. Продолжаем дальше нашу конференцию, и слово предоставляется профессору Безрукову Мартиросяну. Радикальная промежностная простатэктомия, метод выбора в лечении рака предстательной железы низкого онкологического риска.
Уважаемые члены президиума, уважаемые коллеги, сегодня в утренней сессии мы уже обсуждали неоднократно вопрос выбора метода хирургического лечения рака предстательной железы. В своем докладе хотели представить непосредственно результаты нашей клиники выполнения радикальной промежностной простатэктомии при раке предстательной железы низкого онкологического риска. В настоящее время наиболее распространенными методами оперативного лечения предстательной железы является позадилонная, лапароскопическая, роботассистированная простатэктомия, в то время как промежностный доступ выполняется лишь в некоторых лечебных заведениях и не является популярным среди хирургов. На это указывают как данные литературных обзоров, так и данные поисковых запросов в PubMed. По данным литературного обзора нашими европейскими коллегами было отмечено то, что при радикальной промежностной простатэктомии сроки пребывания в стационаре составляют порядка 8 суток, в то время как при лапароскопической и роботассистированной простатэктомии данные цифры они гораздо ниже. Это объясняется тем, что стоимость операции, стоимость расходных материалов, стоимость пребывания в стационаре достаточно дорогой, поэтому пациентов уже на 4-6 сутки переводят в прибольничные гостиницы, где они находятся под наблюдением врачей до момента удаления катетера. Длительность операции при промежностной простатэктомии самое минимально было отмечено 35 минут. В принципе, данные остальные сопоставимы с другими методами. Следует отметить то, что промежностная простатэктомия, она выполняется под непосредственным визуальным контролем хирурга. Поэтому такие хирургические осложнения, как интраоперационное повреждение прямой кишки, инфицирование раны, структура анастомоза, вероятность возникновения положительного хирургического края, они сопоставимы у всех видов простатэктомий. Также, учитывая вышеуказанное, следует отметить то, что удержание мочи, восстановление эрекции, по некоторым данным, даже немножко лучшие данные при промежностном доступе. Критериями отбора пациентов на промежностную простатэктомию является низкий онкологический риск, ожидаемая продолжительность жизни более 10 лет, объем предстательной железы менее 60 кубических сантиметров. Положение больного на операционном столе литотомическое. Рекомендуется использовать специальные фиксирующие устройства с целью уменьшения негативных последствий компрессии нижних конечностей. Под крестец подкладывается валик таким образом, чтобы после установки стола в положении Тарделенбурга промежность оказалась параллельно полу. Также используются плечевые подпоры. Выполняется подковообразный разрез, который проводится на расстоянии 1,5–2 см от анального отверстия, медиальнее на 1 см от бугристости седалищных костей. После рассечения кожи, подкожировой клетчатки и поверхностной фасции рассекается сухожильный центр промежности. Тупым путем создается пространство между основанием простаты и мышцами таза. Дальнейшая мобилизация простаты от мышц, поднимающих задний проход, производится острым путем. В нашей работе мы использовали гармонический ультразвуковой скальпель-диссектор, который позволяет производить диссекцию тканей даже в малодоступных участках раны без повреждения окружающих тканей. В дальнейшем производится выделение и пересечение задней поверхности дистальной части уретры под визуальным контролем. В дальнейшем на дистальную культю уретры накладывается 6 провизорных лигатур монофиламентной нитью монокрил 3,0. Лигатура накладывается на часе 3, 5, 7, 9, 11 часах условного циферблата. Затем пересекается передняя поверхность уретры. Для дальнейшей мобилизации предстательной железы пересекается уретра, при помощи которой производится тракция предстательной железы. Следующим этапом производится дальнейшая мобилизация предстательной железы в области верхушки, передней и боковых ее поверхностей, вплоть до пересечения шейки мочевого пузыря. Острым путем пересекается вначале передняя, а затем и задняя ее полуокружности. Следующим этапом происходит мобилизация семенных пузырьков и семявыносящих протоков. Семявыносящие протоки, они пересекаются, семенные пузырьки, они мобилизируются без нарушения ее целостности. Если после удаления предстательной железы диаметр шейки мочевого пузыря более 8–10 мм, то производится пластика шейки мочевого пузыря по типу теннисной ракетки. Следующим этапом мочевой пузырь проводится уретральный катетер, баллон которого раздувается. Дистально уретра она сшивается с шейкой мочевого пузыря, формируется анастомоз. Производится проверка герметичности анастомоза путем введения 150 мл физиологического раствора. Производится окончательный гемостаз. Раны дренируются хлорвиниловой трубкой, послойно ушиваются. В послеоперационном периоде проводится активная аспирация раневого отделяемого. За период с 2013 по 2015 год в клинике урологии Первого медицинского университета было выполнено 45 промежностных простатэктомий. Средний возраст пациентов составил 62 года. Средний показатель первичного уровня ПСА 6,9 нанограмм на миллилитр. Средний объем предстательной железы 31 кубический сантиметр. Индекс Глиссона был менее или равен 6 баллам. Дооперационная стадия рака предстательной железы Т1 у 31 больного было выявлено, стадия Т2 у 14. Длительность операции в среднем составила 126 минут, средний объем кровопотери 150 мл, сроки пребывания в ОРИД до 1 суток, активация больных на первые сутки, удаление страховых дренажей на 2 и 3 сутки, удаление уретрального катетера на 6 и 8 сутки и длительность пребывания в стационаре 5-8 дней. Учитывая то, что промежностная простатэктомия выполняется под визуальным контролем, это позволяет получать достаточно хорошие функциональные результаты данной операции, в том числе и показатели удержания мочи. У 37 больных было полное удержание мочи, у 7 больных инконтиненция первой степени отмечалась, у одного больного инконтиненция второй степени. Тотального недержания мочи не наблюдалось. Патоморфологическая стадия Т2 у 41 больного была выявлена, ПТ3А у 3, ПТ3Б у 1 больного. По Глиссону 5-6 баллов у 37 больных и у 8 больных было отмечено 7 баллов по шкале Глиссона. Также были отмечены у 3 пациентов такие осложнения, как острая задержка мочеиспускания, была выполнена однократная катетеризация мочевого пузыря, несостоятельность краев после операционной раны у 3 больных и повреждение кишки у 1 пациента. Кровотечение более 100 мл в нашем исследовании не наблюдалось. Спасибо за внимание.
Спасибо большое за ваш доклад. Вопросы будут какие-нибудь? Вопросов нету, да? Спасибо большое еще раз. Значит, мы продолжаем конференцию. И слово предоставляю
Dear Chairman, ladies and gentlemen, I'm very happy to present you the new results of a big European study dealing with rectal cancer, laparoscopic and open surgery. So, tumor surgery needs to make a nice tumor surgery and not cosmetic, but in younger patients it's some advance for this. And what you found in laparoscopic surgery in colon cancer, you have a lot of advances, recovery, pulmonary function, ileus, pain, hospital stay, complications, and morbidity. And one thing, operating time is a little bit longer in laparoscopic. And it's a part of training of the clinic. So if you look to a review and you show you the Cochrane review, you have a lot of advances in laparoscopic surgery, and only operation time is a bad one of laparoscopic surgery. And you have we have a lot of randomized study, but all studies have not enough patients inside. And I would present you the Color 2 study. And now, 2 weeks ago, we can publish the oncologic data of the study. So in colon cancer, we have long-term results. In color study, or in the classic, we had short-term results, and in color 2, now we have long-term results. So if you know you have some things, you must go down to the pelvis. It's narrow pelvis sometimes, and you have preserved the nerves in the pelvic. And the question is it feasible in laparoscopic technique? Is this oncologic safe? Yeah, and the long-term results are okay, and functional results and quality of life. So you can do it in your fashion, but it is recommended to have step-by-step doing. And so if you do it in a stepwise operation, you can save time while the operation. And this Color 2 study, we looked for short and long-term results, sexuality and conversions. And you show the conclusion. What is better, laparoscopic or open surgery? And I show you some evidence till now. Mr. Hiroshi had done a very nice meta-analysis of randomized studies till now. And he found again that operation time is longer in laparoscopic surgery, but he found that in all other things, blood loss or blood transfusion or hospital stay or time to oral diet or late morbidity, the laparoscopic operation was significantly better than open. And in local recurrence, they have found no differences. One-side recurrence, no differences, and no differences in cancer-related mortality. Ileus, it's no difference. And now I show you the results of the Color 2 study. And I present you the long-term results just published 2 weeks ago in New English Journal of Medicine. The trial design was rectum was defined up to 15 centimeters. It was a curative operation, elective surgery, and the randomization type was 2:1 laparoscopic versus open. And we need 1,000 patients to make a nice statistic. It was a non-inferiorial study. And the question was, laparoscopic rectal cancer surgery is not worse than open surgery. And primary outcome, local recurrence in 3 years. And now we have these results. So that was the randomization curve. We was very happy. It's an ideal curve of randomization, and we randomized a little bit too much, 1,100 patients. And we bring in from Regensburg a lot of patients in this study group. It's altogether, it was 30 centers and 2 centers of Regensburg randomized for the studies. Neoadjuvant therapy, it was equally in both chemotherapy and radiotherapy, as there was no difference. That was the randomization type of the lower part of the rectum up to 5 centimeters, the middle part of the rectum 5 to 10, and the proximal part of the rectum 10 to 15 centimeters. And it was a 2:1 randomization, so you have doubles as much patients in the laparoscopic arm. Very shortly, the results postoperatively. We found in directly postoperatively a significant blood loss less in the laparoscopic group. It was high significantly, and operating time was longer for laparoscopy. Conversion rate was altogether 16%. Complete mesorectum excision, a perfect TME procedure, was done in about 90% in 2 arms. It's never published before. It's a very high quality if you mention that you have 30 centers who randomized. Positive margin, the lateral margin to the tumor was measured in this study, and it was no difference in the upper rectum, middle rectum, but we have a better lateral margin in the laparoscopic group, and it was significant in the distal rectum, in the difficult part of the rectum. And very shortly, you have less pain postoperatively after laparoscopy. First bowel move was in 2 days, in 3 days. In laparoscopic group, it was significantly better. Fluid intake and hospital stay was 1 day shorter than open. Morbidity and mortality was comparable. Anastomotic leakage was without differences between the groups, and now published on this in April, beginning April of this year. Altogether, we have 1,044 patients in this group for analysis, and the quality of follow-up was very, very high. In 30 centers, 97%. And we found, and that's the main result, the local recurrence rate in laparoscopic and open was not different. It was 5% versus 5% laparoscopic or open. We have no difference. But we have an intention to treat analysis to do. And if you have grouped the converted patients to the laparoscopic group, and if you keep it to the open group, you have a slightly better recurrence rate in laparoscopy compared to open. And as you demonstrated, the lateral distance was better in the laparoscopic group in the lower rectum, and now we found that local recurrence is better in the laparoscopic group compared to the open group, and this is significantly better in the distal part of the rectum. And very surprisingly, looking to long-term outcome and look to the tumor-free survival, we found no differences in all stadiums, and we found a slightly better Kaplan-Meier curve in the stadium 1 in favor to the laparoscopic group, not in stadium 2, but in the larger tumors in stadium 3, we have a significantly better tumor-free survival after laparoscopic surgery. It was really surprisingly. So other things you are interested is what's about sexual dysfunction, and the patients are about nearly 70 years old, and you see you have a lot of sexual dysfunction before operation, about 60%, and it's rising up to about 80%, and in 3 years, in 12 months, you have a problem in about 75% in average in both groups. Risk of conversion. Why should I convert? It was 60% in this study, and it was high age, and it was a high BMI. The obese patients are converted more often. So, in conclusion, laparoscopic surgery for rectal cancer is associated with similar local rectal recurrence rate considering the whole rectum, lower local regional recurrence rate for the lower third of the rectum, and surprisingly a significant better disease-free survival in stadium 3 in rectal cancer. So one must say we have now clear evidence in favor to laparoscopic colorectal cancer surgery, and laparoscopic surgery in rectal cancer can be recommended. So take-home messages: it is feasible, it's safe. One should standardize the laparoscopic technique to spare time, operation time. Do it with the same or the best oncologic expertise, and it's very essential to create a laparoscopic team. Thank you very much for your attention.
Спасибо большое. Вопросы есть у кого-нибудь? Вопросов нету. Еще раз спасибо. Мы продолжаем. Слово предоставляется Вольфу Фердинанду Виланду со следующим докладом. Протезирование полового члена.
You have it in German also? Is that? Yes, yes, very, very nice. So, you know, I'm talking about penile implants, you know, I don't know how often you do that in Russia. I think not so often, because usually the patient has to pay it out of his own pocket. In Germany also, but, you know, if you have a certification of the insurance company that all the other therapies like PDF5 inhibitors, injection to the corpora cavernosus, the so-called SCAT therapy, and all the other methods have failed, then you can, the insurance company will pay for it, because only the device, the cost of the device is around 6,000 euros. Okay, but let's start now. I just want to make this confirmation before, that you know what we're talking about. We do around 15 to 20 penile prostheses per year in the clinic. So the reason is, or the cause for this penile prosthesis, it's the end stage of an erectile dysfunction. Is impotent, you know. This is just for the history. This was a patent schrift, what we call for the patent from Otto Lederer, done in 1913 in Vienna, and he was the one who developed the vacuum extraction pump, which you can find now in every sex shop now. Then the 1998 was the next very important step. It was the step for the PDA5 inhibitors. And the PDA5 inhibitors, the most popular was Viagra, which is now under the license for Viagra is now out, so you can have it much cheaper than before. Before it was quite expensive, like still the other ones, Levitra and Cialis. And there is a fourth one, which is called Spedra. I don't know if you know this in Russia. This is the fourth one, which has a very high dose of sildenafil. It's very similar to sildenafil. So you know, the Viagra, the strongest Viagra has 100 milligrams, and this Spedra has 200 milligrams. So it's for severe cases. So this is very interesting. This guy was an army doctor, and he was the one who started first, and he found out this cut therapy. And it's quite interesting, and he could show that you make a prostaglandin injection to the corpora cavernosa, then you have an erection which lasts about half an hour. A lot of patients after radical prostatectomy do this. And this guy, he has reported about this on a meeting like this, you know, and nobody believed him. So it's really a true story. He went out and made an injection. He came back and he was here like this. And then he asked people, okay, come, I can show you now what happens to me. And he did it really during his presentation. It was 1983. And now this Brantley Scott, he was the founder of the first penile prosthesis. Okay. So the frequency of erectile dysfunction is, it's quite high. You know, it has a progression with the age, that's for sure. But it's, you see here with 60, 69, more than a third, or around a third of men have problems with erectile function. So the frequency of severe erectile dysfunction is around 16% with men over 60 years. So sexual activity, and that is very important. You see that even older men, even between 70 and 79, are sexual active. So you have to offer these patients something, and it must not be the penile prosthesis, because it is always the last step, but you have to think about this. So the frequency, the treatment, or people asking for treatment, only 20%, because it's very similar to the incontinence in women. They are ashamed, they don't want to go to the doctor and talking about this. So the frequency of severe erectile dysfunction, you see how this chart goes on, what you have to do, what kind of examinations you have to do. I don't want to go not deeper to this, because you can see these are normal examinations, what you do with somebody who has this erectile dysfunction. So recommendations for this diagnostic workup of erectile dysfunction are in a level, you see, it's not a high level. You have a level of evidence of 3 and 4. So these are the recommendations of the European Association of Urology. So germ-based therapy, you can see reversible causes, removal of the drug, changing lifestyles, testosterone replacement therapy, if the patient has not a prostatic cancer. Then first-line therapy always are the PDE5 inhibitors, or also sexual therapy by psychologists. Second-line therapy is a vacuum pump, what I show you, the Muse and the SCAT therapy. And there is something, it's not on this slide, it's Virtus. It's a new cream, what you can do on the glands, and which is also prostaglandin cream. It's very new in the market, which also has an effect on an erectile dysfunction. And the third line therapy is penile implants. And you see some of these patients go, especially when they asking for this and paid from their own pockets, they go from the first line therapy directly to the third line therapy. So I want to just show you, this was the first penile prosthesis was developed, and this is now the penile prosthesis we are using now. And you see here that the two implants in the corpora cavernosa, then the water reservoir and the pump with this knob here you see, where you can release the water, what you have pumped before into these two cuffs, you know. So this is how it works, you know. What is very important is you have to ask the patient, is he a right-handed or a left-handed? Because when it's a right-handed, you have to implant this pump on the right side of the on the right scrotum, if it's a left-handed, and the left scrotum. He can handle this better with from the dexterity, you know, of the hands, you know. So you can understand how this worked, and then you can. And what is really incredible is these patients can have a normal erection, and they can control time of erection. So these men with these pumps are really quite dangerous because they are able to have intercourse as long as they can tolerate it. So the volume changes from the cylinders have changes in the last time. You can also have now the possibility to so you can make a little bit the penis longer with this device. So that is a pump. With this pump, you pump pump out the water from the reservoir into these cylinders, and with this knob you can release it. Then when after the erection, that the penis goes down again, or it has to go down again. So this is the shape of the cylinder, which changes now from round to this shape, you know, because you have to place this cylinder paravesical. So this kind of, or this shape is mostly more convenient because you don't have to make such a big area to create a big area besides the bladder. So you can see how again this shapes, and the most convenient is this with 100 milliliters, but they have now developed also 100 milliliter in this shape now. Okay, then it's something technical about this filling volume of these cylinders, but this is not so important. Then you have, if somebody has no longer erection, this normal erection, what you have to talk with the patients. The penis can be a little bit thinner when you have this, when you implant this device, and also a little bit shorter. But with the new devices, you can really also make it a little bit longer. You know, it's always there are technical developments which came up in the last years, and what is very important, the mechanical damage is in about 5% of the cases over 10 years, and that is quite good, you know. So this device is now developed very, very well, and it's, you know, it's quite long on the market. So it's not a new device which has to be proven in the first years, you know. This is the way you should pump it. You know, you see here on the right side, you have to talk with the patient very, very precisely, because you have to tell him that I want to do that this is the end stage, because to bring in these cylinders, we have to destroy the whole corpora cavernosa. That is very important, that he knows this. That is the end stage. After this, that is nothing anymore. So what is very important, you have to do, because when you implant this device to avoid infections, you have to do 3 days before chlorhexidine spray 3 times per day in the anogenital region, 1 day before shower, soap, beta-isodona, and day of the surgery, washing with beta-isodona, shaving 50 minutes with a special infection and anti-infection liquid, and long time disinfection. And what we also give the patients gets the day before an antibiotics, and he gets also antibiotics postoperatively for 3 days. So this, you saw this surface is yellow from these devices. It's also quite new. It is a coated antibiotics which now covers the whole device, and this is also, it makes it's a better much better to avoid infections. And this is a coating with tetracycline and rifampicin, which is already on these devices when you get it from the company. So the surgical technique now, the surgical technique is not very difficult. It's quite easy to do for an experienced urologist. You can do it. The access is penoscrotal. You make a preparation of both corpora cavernosa, like you see here. This is the ureter, the both corpora cavernosa. Then you cut here the knife, the corpora cavernosa on both sides in the same layer. Then you have to see here now. Then you have to destroy with a bushy the whole corpora cavernosa to the glands, in the direction of the glands, and it is also very important down to the cruise of the corpora cavernosa. And this is very important that you have to explain the patient. It's the so-called effect of Concord, because every urologist knows that you can only have an strengthness of the both corpora cavernosa. The urethra and the glands are a different corpus cavernosa. So if you implant this device, the glands will always be a little bit flaccid. It's not as rigid like the corpora cavernosa, and therefore call it, this is the so-called effect of Concord. And you see here how we bushy, how we destroy the whole corpora cavernosa with some special bushes which are in this set, and then you bring in this device also with a special set which you get from the company, and then you implant this 2 cylinders in both corpora cavernosa, and now you have to implant the pump, let's say here on the right-handed man on the right side, and from this access you also can, it's possible to implant the reservoir, because the reservoir is very important. You have to go to paravesica. If this is an obese patient, and so I prefer to make a little incision paramedian in the medial incision to implant this reservoir, and then you can close the different layers, and it's done. You see, it's technically not an easy operation, and what we are doing is, we cover everything with this contactless technology layer to avoid any kind of infection. If you have to do that, you can argue about this, but it's also offered from this company that you avoid any kind of infection. So the postoperative management, the implant remains light filled for the 2-3 days, also to have a compression to avoid bleeding inside the corpora cavernosa. Then you have to give the patient a catheter, urinary catheters for 3 days, and from the fourth days after the operation day, the implant should be 1 to 2 times per day pumped in fully, that you see that you can a little bit stretch the corpora cavernosa. And then what is important, a daily change position of the pump, you have always to bring down the pump every day, let's say 1 week, around 1 week. And you have to tell the patient he can try the first time after 6 weeks. He has to wait 6 weeks. After 6 weeks, then he can first, when he is trained accurately, with he can start to try intercourse with this new device. And the patient satisfaction with different treatments, you see, that is very important to see. Penile injections around 40%, oral medications 50%, and with the penile implant 90%. And they are not very happy with this, the patients, so also the partners. So it's important that you don't only speak with this patient, you also speak with the partner, and they are, you see, the satisfaction for this kind of treatment is very, very high. So unsatisfactory sexuality is going down. We see quite a lot, and you see. Let me come to the conclusion. The frequency of ED is about 50% or more with 60 risk factors, as I told you, age and vascular insufficiency. Implantation according standards leads to high acceptability. Satisfaction of the couple is quite sure. But it's very important. You have to talk with the patient. You have to explain him very, very well. And accepting of treatment costs by the medical insurance companies are in Germany are possible when you have a certification that all the other therapies fail. So I hope I showed you some interesting
Большое спасибо.
presentation. Thank you very much.
Большое спасибо еще раз. Вопросы будут? Всем все понятно, вопросов нет, да? Тогда мы продолжаем. Шайков. Современные возможности компьютерной магнитно-резонансной томографии в урологии.
Здравствуйте. Я расскажу о тех решениях, о тех технологиях, которые предлагает Siemens именно для урологов. Значит, если структурировать эти технологии, то это флюороскопические приборы, используемые в эндоурологии. Это аппараты для уродиагностики, рентген, КТ, МРТ, УЗИ, ПЭТ-КТ, МР-ПЭТ. И это дистанционные литотрипсии. Начну с литотрипсии. Siemens имеет дистанционный компактный модульный литотриптор, который называется модулярис. Чем он хорош? Это высокоэффективной ударной волной, в то же время с малым количеством побочных эффектов. И достигается это за счет большой фокусной зоны и низкой плотности энергии. Представьте, что вам наступили на ногу такими туфлями или такими каблуками. Одна и та же энергия, один и тот же вес, но различная плотность. И, соответственно, болевые ощущения будут разными. И вот вы видите в сравнении с конкурентами, фокус у Siemens самый большой, что делает волну наиболее эффективной. 3 вида СИДУК для рентгеновского наведения могут использоваться в данном литотрипторе, ну, также УЗИ-аппарат. СИДУГи. На сегодняшний день Siemens имеет линейку из 5 рентгенхирургических аппаратов. Наиболее интересный аппарат Arcadis Orbic. который характерен полной изоцентричностью. То есть центральный луч пучка всегда проходит через изоцентр. И это устраняет в необходимости повторно позиционироваться, экономит время, снижает лучевую нагрузку. Также в этой дуге орбитальное движение 190 градусов, в отличие от традиционных 120-140 градусов. Еще одна дуга интересная, это дуга высокой мощности 25 киловатт с сури 33 сантиметра. Ангиографические аппараты. Довольно широкая линейка с настенным креплением, с потолочным, с напольным, с двумя трубками, биплановые аппараты. Для урологов наиболее интересны могут быть потолочные системы, либо роботизированная система. Вот и та, и другая, они могут использоваться, могут двигаться, и когда не нужно, то они отъезжают от стола. Можно запустить видео. Что не запускается. Вот примерно так вот выглядит сканирование с помощью роботизированного ангиографа. Значит, с помощью ангиографа можно получать КТ-подобные сканы, и я расскажу, для чего это нужно. Ну, например, при лапароскопической нефректомии одна или несколько почечных артерий или сегментарных артерий должны быть клипированы, чтобы избежать кровотечения. И без интерпретационной визуализации трудно увидеть, какая артерия или артерии питают опухоль. И благодаря 3D-визуализации, включая питающие сосуды, ну, можно увидеть питающие опухоль сосуды. И это позволяет селективно клипировать питающие опухоль сосуды. Также часто бывает недостаточно собственной визуализации тактильных ощущений при минимально инвазивном доступе через небольшие разрезы. И глубина резекции опухоли не ясна. КТ-подобное сканирование позволяет совмещать предоперационные и интероперационные изображения и визуализировать хирургические инструменты по отношению к анатомии пациента в реальном времени. Это помогает определить объем операции, чтобы обеспечить запас безопасности вокруг опухоли. Также при стандартные рентген-диагностические и УЗИ-системы не предназначены для 3D-визуализации чашечно-лаканочной системы почки. И пункции бывает сложно проводить только при 2D-визуализации. Здесь мы можем предложить наведение с помощью специального лазерного указателя для безопасной установки игл и катетеров. Вот